So I'm recording the session now. It doesn't always work either, but I like to start with the disclaimer that we do the best we can in making this web accessible and making it available to people who are not able to drive and park the car. We have advantages, we have disadvantages. It's socially clunky, which means that there are a couple of people who are online. You can see on my screen, they can't see. But right now, Edney, Jean, Julie, Diane, Jean Phipps, and there's two of me because I made sure it wouldn't time out, put two of me in it, are logged in. And Keith will come in and out, and so will other people. So they log in. Hopefully they don't make noise. My disclaimer has always been, if I hear the dog barking or the children crying, I will mute you. I will mute your phone. So you will only be able to chat in the window. You guys don't get muted. But if someone is out and, you know, the buzzers are going off, I will mute it because I have the power to do that. Nonetheless, what I like to do is make it as formal as we can. I'm going to get this screen out of everybody's way. Today we have 4 EVP projects that you will hear, and Dr. Debra Hanna will introduce them, and then I'll also get in the way with trying to give everybody the keyboard and give them control of the keyboard so they can also present. So I'm going to let her use her screen to describe all 4 to start. That way, in the video replay, you'll be able to have introduced each one when we start fiddling with the screen. Sound good? Okay, Dr. Hanna. Yeah. It's always good to do that.
Okay, good morning. I'm going to be presenting 4 of our students in the CNS Postmaster's Certificate Program who will present their evidence-based practice projects. And I would like to thank the people at Memorial Sloan Kettering for having sponsored our students and providing preceptors for them. But one of the issues, or one of the things at Sloan Kettering, was that the students were provided with a topic, and then the students took that away and did an evidence-based practice project on different topics with their preceptors and the specialties that they had. And so we're going to hear from 4 different types of evidence-based practice projects today from 4 different students. First, we're going to have Jean Phipps, who is currently a nurse educator at Mount Sinai in Manhattan. And Jean Phipps's background is basically in women's health. So she worked with disciplines on a women's oncology unit, M10 at Memorial Sloan Kettering, and her project is the effects of using enhanced recovery after surgery program for patients undergoing ovarian debulking surgeries. After that, we'll hear from Jean Edney, who will be presenting her work that she did on a colorectal service with Debra Rodriguez, who was her preceptor. That was on M15 at Memorial Sloan Kettering. And she had to update a standard, and she'll tell you the interesting story of how one standard, through the evidence, ended up becoming 4 standards. Then we'll have Joseph Brian Tebo, we'd like to call him Brian, and he is currently a clinical nurse educator at New York Presbyterian Columbia, and his specialty is oncology. And so Brian will be presenting a standardized protocol for managing hypersensitivity reaction to patients receiving blood products, which is actually much more complex than I ever knew it was, but Brian has some good information. And then finally, we'll be hearing from Maria Del Mar Rodriguez, who is currently a CN2 nurse in the operating room at Memorial Sloan Kettering. And she did a very interesting study based on a gap in knowledge that she saw, and that had to do with how post-operative handoffs were given from the pre-op nurse to the operating room nurses, and then from the operating room non-nurses to the PACU nurses. So she did a very nice survey, and we'll hear about her work. So we'll start first with Jean Phipps, who is presenting, what would you call it, through electronically or?
Magic. Call it magic.
Yes, through magic.
If it works.
Okay, so.
I'll give Jean the controls. Jean Phipps, you've been introduced, and I'm about to change and give you control of the keyboard. So if you don't have control yet, but you will shortly.
Okay.
And she's here, I think. No, wrong one. Hold on. There you go. I'm going to get it started, and then I'm going to give you control. Put your cursor in the middle if you can. Slide. And there you go. You're on.
All right. Good afternoon, everyone. My name is Jean Phipps. I'm going to be presenting on the enhanced recovery after surgery, taking a look into program sustainability. So one of the reasons, give you a little background on this program, my preceptor identified that they started the enhanced recovery program on their unit in April of 2017. So we just wanted to see if it's basically successful, and if not, we want to identify any problems or issues that we might be able to rectify so that it is sustainable. So enhanced recovery after surgery was developed by Hendrik Catal in the 1990s. It was first used on the colorectal unit at Memorial Sloan Kettering, and it was started in the Women's Health Oncology unit in April of 2017. And the evidence-based audit project was conducted during the fall and summer of 2018 of this year. So there are key elements of the enhanced recovery after surgery. One is pre-op management, where the patient is educated that they can have a carbohydrate loading diet up to 2 hours prior to surgery, and clear liquids up to 2 hours prior to surgery. The traditional model was that they, of course, usually when you have pre-op patients, you advise them to be NPO after 12 midnight. But with the enhanced recovery after surgery, the patients can actually have fluids up to 2 hours prior to surgery. Intraoperative management includes pain management with non-opioid analgesics. We want short-acting medications, eliminate drain placement, and we also would like fluid management. Post-operatively, we encourage early feeding. We want to maximize pain control and reduce opioid use. We encourage early mobilization, and if a Foley is in place, we want it to be removed right in the PACU area, and we also want fluid management as well. So the significance was that implementation of ERAS, for short, which is enhanced recovery after surgery, is associated with reduced hospital length of stay. The average was about 2.28 days, 2.2 days reduction in hospital stay, reduced hospital costs, significantly reduced post-operative morbidity, and improved pain management. At Memorial Sloan Kettering, we identified the patients that were started on ERAS as the ovarian debulking cancer patients. And because of this disease, it involves a lot of manipulation of the abdominal area and extensive debridement. So the average length of stay before implementation of ERAS was between 7 and 10 days based upon the extent of this particular surgery. Our aim, or the aim of Sloan, was to reduce the length of stay to 5 days, and that's why they started to place the ERAS protocol for ovarian debulking patients. Documented cost savings is as much as $7,600 per patient. So it's actually something that was incorporated into the entire process. So two PICOT questions were developed. One is, in ovarian debulking patients, how does an enhanced recovery after surgery program compared to a traditional surgical approach affect patients' length of stay? And the second was, in ovarian cancer patient, how does an enhanced recovery after surgery program compared to a traditional surgical approach affect post-op abdominal complications? So here are the differences between the traditional model and the ERAS protocol. So usually, again, traditionally, we were told to be NPO after 12 midnight. Again, with the ERAS protocol, there's patient education in terms of their diet. Intraoperatively, we usually limit fluid intake. There's no limits rather in fluid intake. Usually the anesthesiologist or the provider, especially if there's any bleeding identified, loads them in with a lot of IV fluid. There's usually long-acting pain medications and usually placement of drains. With the ERAS protocol, we want to use short-acting pain medications. We want to eliminate the use of drains as much as possible. I mean, if it has to be used, of course, we have to use our critical thinking when it comes to that. However, we want to make sure that we eliminate JP drains and as much drainage as possible, and also fluid management intraoperatively. And post-operatively, normally traditional practice with opioids for pain, usually have a Foley catheter in. Bed rest is usually encouraged. Diet is cleared, and then advance is tolerated. But with the ERAS protocol, feeding is start right after surgery, right in PACU, before they even report to the floor. There's encourage and maximum use with pain control. We want to reduce opioid use, encourage mobilization. Sometimes this starts right in PACU. Early urinary catheter removal, fluid management, and it's dependent, of course, on the disease process that's in place and how extensive and how, if there are any complications in the OR, we take that into play before we initiate the ERAS protocol. So with that, we're hoping to, the reduction we want to see is 5 days of length of stay. So after implementing the ERAS program in April of 2017, we evaluated which variables, if any, might affect patient length of stay. So as a result of that, I decided to do some chart audits, as the literature suggests, to determine if ERAS would be successful. So the purpose of the review was to identify any problematic variables, compare findings with current recommendations in literature. We wanted to analyze adherence to the policy and standards that were already in place for ERAS and provide recommendations based on the current findings, literature findings. So the search terms that were used were ovarian debulking, enhanced recovery after surgery, gynecology, post-op ileus, and length of stay. Levels of evidence were significant. I had a lot of level 1 systematic or meta-analysis reviews. I had 14 literature results, and so I had a lot of high level 1 levels of evidence. The levels of evidence supported preoperative patient education in most of the charts. Preoperative diet, everything was in a positive upward trend. Mechanical bowel prep, fluid balance and management was supported. Pain management was supported. Minimal use of drainage was highly supported in every article, and early mobilization was supported in every article. So initially, there were really 116 charts, that I had to go through to narrow it down to 46 that were identified as true ovarian debulking patients and ERAS, patients that were placed on the ERAS protocol. So the common morbidities that I saw was post-op ileus, abdominal distension and abdominal pain, blood transfusions, post-operative fever, respiratory distress, tachycardia, dizziness, elevated blood pressure, and chest tube placement. However, the top 3, post-op ileus, abdominal pain, and blood transfusions were the most comorbidities that I saw with the 46 charts audited. So this is the internal evidence of affecting length of stay. And again, we see some form of abdominal dysfunction was in 14 out of the 46 charts, and post-op ileus. So something where it had to do with abdominal disturbance. So 35% of the 46 charts audited included patients, as I said before, with some form of abdominal dysfunction. the key that was, or something that was glaring to me, is that the IV fluid intake had wide variations when I looked at the anesthesia record. It ranged from 1,200 to 9,750 cc's total. And I understand when I reached out to the CNS that it was variable factors, because if the patient became hypotensive, of course you want a bolus because you might think that they need the fluid. And for inpatient fluid management, we didn't have a clear or standard set of what the patient actually consumed. So those were some of the variables that we found when auditing the chart. Also, the anesthesia record didn't show a correlation between the fluid administration and estimated blood loss or ascites drainage, because some patients did have some ascites drainage. However, for example, if a patient was drained of 600 cc's of fluid of ascites because of the ascites, they still, some of them received, for example, I had a patient that received over 3,500 cc's of fluid in the OR. However, they didn't have any excessive bleeding. The EVL was 250 and the ascites drainage was 650. It didn't correlate with the 3,500 fluid intake. So those are some of the things that I found in the chart audit. Oh, this is going back. Okay. So external evidence. So in one of the studies done by Barber and Van Lee in 2016, it recommended that the goal of ERAS is to weigh the patient entering surgery should equal the weight of the patient exiting the surgery. Fluid-directed therapy, we recommended using minimal invasive devices such as esophageal Dopplers to measure cardiac output during surgery, and this should be aimed towards maintaining optimal cardiac output. Also, a meta-analysis study identified goal-directed IV fluid therapy with patients undergoing abdominal surgery, and it has shown decreased length of stay, fewer complications, fewer ICU admissions, and decreased nausea and vomiting. It also identified that a restrictive fluid policy is associated with improved outcomes compared to the traditional approach. There was also two separate Swedish studies that identified that failure to follow restriction of IV fluids and the use of pre-op carbohydrate drink were the only independent factors that strongly predicted a poor post-operative outcome. So as we can see, there's strong evidence with linking the amount of IV fluids given to the patient with increased length of stay and some form of abdominal dysfunction. In a retrospective cohort study, it said that intraoperative crystalloids of at least 500 to 1,000 cc for surgery less than 3 hours is recommended. Otherwise, between 1,500, the maximum is 1,500 cc's, and colloids between 5 and 1,000. Post-operative crystalloids should be 500 cc's during the first 24 hours post-operatively, and then it should stop. So a lot of the evidence in the literature supported IV goal-directed therapy where you monitor it judiciously, and also to decrease the amount of fluid intra-op during surgery. There were limitations that were identified, and some of them were that with all the literature reviewed, with the exception of the previous slide, there was no clear recommendations of what the fluid management should be. It didn't specify it should be 100 cc per hour or 10 cc per hour, so we couldn't really pull anything from the literature to make a policy to say that patients that are in the OR intra-op should get X amount of fluid versus PACU. So that's one of the limitations that identified. Hemodynamic parameters and monitoring strategies to guide fluid management in those patients weren't clearly identified. The overall consensus is that in order to achieve ERAS protocol, however, is that all requirements of minimal invasive processes must be maintained. So that was basically extracted from the literature, is that all the requirements of ERAS that were put into place by Mr. Henry Catal in the 1990s should be in place for your program to be successful. So recommendations, we want to continue to collaborate with the preoperative, intraoperative, and postoperative areas to look at variables impacting IV fluid administration and goal-directed therapy. We want to create a flow sheet for nurses to document ongoing assessments and milestones met. Change the order set to strict I's and O's for the first 24 hours to reflect current recommendations of IV fluids between 40 cc's until tolerating 600 cc's per mouth. That's just from one research. We didn't have strong evidence of that, but that's just something that we could pull from one of the studies. And we are, the CNS, that's my preceptors, currently conducts rounds on patients and will continue to audit the charts to see if there's improvement once we go back to the team with these recommendations. And we also we want to look at creating a nursing standard of care for gynecological surgical patients. And that's it. Thank you so much.
Great. So Jean, can you hear the applause?
Pardon?
Could you hear the applause?
Yes, thank you so much.
Okay, I'm going to take controls back. So
Okay.
Don't touch the screen
Any
or your
questions?
mouse anymore. I'm going to give controls to the room now because I believe that. Oh, okay, Jean Ann, you're up next. I'm going to give you controls after I get your slides up. Hold on a second.
Okay.
And I will, there you are, you're actually already up. And you'll see that you're up, right?
Yes.
That looks good to you? All right, now give me a moment and I'll make sure that you have control.
Okay.
Hold on a second.
Are we doing questions for the first presentation?
I'd like to run through all four, if that's okay. Okay. What I'll do is Jean, that is, which Jean?
Jean Phipps.
Jean Ann. Okay. Jean Ann, stand by. And Jean Phipps, I think your classmates want to ask you questions, but I don't have your slides up anymore.
I wanted to find out if they had any questions because I have to get back because unfortunately we are preparing for joint commission.
All right, so I'm going to stand in the room so you know I'll direct the questions. Okay. You should be able to hear them in the room. The microphones do work, even in the back.
I have one question.
Okay.
Okay. Dr. Hanna has a question. I'll put her in the front.
Okay.
Jean, do you think that you can explain to us how you realized that there was an issue about the amount of the intraoperative fluid? Like, what was it that really put you into that?
Sure. So during the chart audits, I really couldn't find anything that stood out. And then I did a deeper dive because we had certain checklists that I thought were pertinent. Like, let me look at the Foley, if they had a Foley. Let me see if they had a lot of complications, what were the particular complications. So once I identified that there were a lot of abdominal related issues, I started thinking about the fluid intake because to me, as we know with evidence, when you have the IV fluids, there's salt and it actually causes swelling or edema. So that would increase the swelling of the colon or the abdominal area. So I said, well, let me start to look at the IV fluids. I couldn't find consistency in the I's and O's in the chart, the EMR, but what I had to dig deeper into was the anesthesia record. That's where I got all to me, the most accurate IV intake and output. And once I looked into that, I saw that there was a significant discrepancy between the amount of fluid each patient received, and it didn't correlate with their OR intra-op process. For example, if there was 2,000 cc's blood loss, I wouldn't still expect a lot of IV fluid because you need to replace it with blood. So I saw a lot of IV fluid used, but not too many patients had any EBL that it was above 500. It was more ascites drainage. And I'm saying, well, why is this patient getting so much fluid? So the only thing that made sense to myself and Cecina, my preceptor, was that these patients were being overloaded intra-op. And that is why we were seeing patients staying longer than the 5 days because there wasn't a strict management of IV fluids in the OR and post-operatively.
Okay,
as recommended by the literature.
Yeah, thank you. Are there any other questions for Jean? I think we're good, Jean. So thank you very much for your presentation. We really appreciated that.
Thank you so much, Dr. Hanna, and thank you all. I'm sorry I have to leave, but I have to get back to work. I'm so apologize.
Okay.
Thank you so much, everyone, for the opportunity.
Okay.
Be sure to exit the meeting.
The meeting.
Pardon?
Be sure to exit the meeting.
Okay, thank you.
Thank you.
You want to introduce Jean Ann? Because Jean Ann, okay, she has the control. Oh,
Jean Ann has the controls, right?
no, that was Jean Phipps that has the controls. Jean Ann, circle the
Hi.
slide again, grab control. There you go. You got control.
Okay.
All right, you're on.
Okay.
So
Okay.
go ahead. Take it away, Jean Ann.
Okay. Hi. Good afternoon, everyone. My name is Jean Ann. Can you hear me okay? Am I talking too loud?
No, it's fine.
Yeah, we can hear
Okay. Okay. So good afternoon. I'm so sorry I couldn't be there in person. But what I will be presenting today is, using evidence to update the wound ostomy and continence nurses standard of care. And I'll explain, how and why a standard of care was even necessary for our WOC RNs at Memorial Sloan Kettering and the steps taken to create the evidence-based standard of care. Okay, so just to give a background, there are approximately 800,000 people currently living with an ostomy, and about 120,000 new ostomies are created annually in the United States and in Canada. Up to 80% of patients will experience ostomy complications, which can include peristomal skin complications. This is the greatest one, dehydration, and this is specifically for patients with ileostomies and with any kind of genitourinary stoma and mechanical injury. The post-op length of stay has decreased, in recent years due to laparoscopic and robotic surgical techniques and enhanced recovery after surgery, so ERAS protocols, which are, streamlined pathways. And these shorter hospital stays have decreased the amount of time patients can receive post-op education. And our WC RNs play a key role in educating and coordinating care to transition patients to becoming independent with their ostomies. Oh, sorry. Okay, so the problem identified was that enhanced recovery after surgery, so ERAS, it's this multimodal program that's developed to decrease post-op implications, improve patient safety and satisfaction, and promote early discharge. And since the implementation of ERAS, some patient discharges have been postponed due to a delay in independent stoma management. And since pre-op, post-op, and post-discharge follow-up are necessary to provide optimal outcomes, a standard was needed at MSK for when and how education should be completed by the WOC RNs to help patients achieve their self-management skills before discharge. So this delay in independent stoma management can occur across the services of colorectal, genitourinary, and in GYN surgery, where patients sometimes to do the debulking require an ostomy. So during the post-op period, what they were finding was patients were recovering from surgery, potentially, receiving opiates that made them sleepy, and adjusting to their new ostomy simultaneously. And this presented a challenge for the WOC RNs and the nursing staff in how to best educate these patients when they should be providing the ostomy education and the skills needed to be able to manage at home, all while simultaneously addressing the individual psychosocial needs of the patient. So the role of the WOC RN and the importance of their services provided to patients has been recognized in the literature and was noted to be imperative for the education and recovery process for patients with newly formed stoma or stomas. The question, however, is what is the best way to provide this education at Memorial, which led to our PICO question in nursing. How does a standardized ostomy educational program compared to usual care affect patient education? So as someone was needed to take on this evidence-based project, I was placed with my preceptor, Debra Rodrigue, who was on M15, which is the colorectal inpatient floor to develop this standard of care to ensure the individual needs of patients requiring an ostomy are being met across the education spectrum. So the goal of this project was to develop and implement an evidence-based ostomy-specific best practice guideline that will address the education associated with pre-op, post-op, and discharge phases of care, and to develop a clinical guideline that will be the foundation to develop a standard of care for the delivery of stoma education. And to date, one of the limitations that we had noted when we were doing our literature review, and I'll go into this a little bit more later, was there was a lack of evidence showing specifically what education should be taught on specific pre-op and post-op days for developing the stoma skills. So therefore, because of that, we use the most recent guidelines in the Wound, Ostomy, and Continence Nurses Society and our level 1 study that we reviewed, which was a systematic review, and we referred to that quite frequently to address certain components of how education should be addressed. So here were our search terms that we used. So surgical stoma, patient education stoma, continence nursing, stoma care nursing, WOCRN, and these were the 3 search strategies and databases. And then after reviewing 33 articles that we critically appraised for our PICO question, 9 were not used after the review, so we kept 24 studies after appraising them. So after appraisal of the articles, our next steps included involving our stakeholders, who were the WOCRNs for the colorectal service, genitourinary surgery, and for GYN. And this included both on the inpatient side and on the outpatient side. And then we assessed the current workflow. So in doing this looked at the current workflows across these 3 services, again, on the inpatient side and on the outpatient side, and comparing the current workflows to the best practice between pre-op, post-op, and post-discharge follow-up for these patients. So after reviewing the articles and looking at the workflows of the 3 surgical services, the literature was placed into our level of evidence tables. As it's all, here. As you could see, we had mostly level 7 studies, and then we had our level 1 study here. And then our outcomes were then bucketed into major topics to better organize the data review. So the bold here, in the black bold, indicates major topics that we then used to create the standard of care, as these were the most common, denominators in all of the studies. And then we created another timing of education, was also reviewed. So this was all, as you can see, the pre-op education, post-op, post-discharge. These were the ones that were most frequently seen, as well as the telephone follow-up, which we then found out was in the current workflow already. And then we had a topics of education outcomes. So these were the topics that were most frequently reviewed: developing stoma care skills, nutrition education, nutritional screening, and maintaining adequate hydration and high output management, which is most pertinent to the genitourinary population and for the patients with ileostomies. So to summarize, the tables and everything that we found that having a consistent approach to education should be provided in all the phases of care, in pre-op, post-op, and post-discharge follow-up. A multimodal approach is best for all learning types. The education best provided by a WOCRN. However, the literature suggests having these ostomy champions, which are the staff nurses, to provide education in the absence of a WOCRN is okay to do. The literature is very clear that only a WOCRN can mark a patient for their stoma site. And it is imperative that patients have basic stoma skills and baseline knowledge of how to maintain hydration prior to discharge home, and that's in order to prevent complications. So again, our other key points is that although the evidence did not specify when is the most appropriate time, whether it's pre-op, post-op, or post-discharge follow-up, maintaining a consistent approach in how the education is provided is really the key here, and that intensive, individualized pre-op education can enhance the patient's ability to adjust to and manage an ostomy. The discharge planning must be initiated prior to surgery, so even on the pre-op side before they're even admitted for surgery. Because patients have individual responses and coping strategies vary, stoma care education needs to be approached in a holistic manner to meet individual needs. And emotional and psychological support needs to be provided simultaneously with the development of these practical skills. And currently, the American Society of Colon and Rectal Surgeons advocates for pre-op and post-op care by WOC RNs. So where we are right now, as far as where this standard of care is, so after all the evidence was collected, reviewed, bucketed into tables, our next steps was to create the actual standard of care for it to go live. And we found that in general, the surgical services of colorectal, GU, and GYN were doing a great job in delivering evidence-based patient education on the pre-op, post-op, post-discharge side already. We just needed to standardize it across the services so that everyone was doing the same thing at the same time, educating the patients so that they can all have the ideal outcome. So we developed the standard of care, and then it's actually posted right now on our intranet site. So I took a screenshot, and that's what this slide shows. So the WOCRNs, we had asked for their input as I was going on with the standard of care, just for their feedback. And then it is posted now until next Friday, so they could just make comments. And just to show you an idea of what it looks like. So you could see here, this is for the standard for initial post-op visit inpatient when they're seen, but I also have one for pre-op. I have one for their second post-op visit inpatient, and then their one prior to discharge, and then another one that's post-discharge follow-up. So that's at the post-op back on the clinic side again. And within this, what they can do is then click on the link. So the WOCRN can click on the link, and it just prints right out to the patient education that the patient should have for that specific surgery, and they can print it out and just give it to the patient. So one of the limitations, or several of the limitations that we had, was it was difficult to compare multimodal interventions to draw any conclusions as to the best practice. There's no specific recommendations given as to when or how is the best way to provide education. There is little research on the most effective way patients develop practical stoma care skills. And another, key point at our institution is that most of the literature does not focus specifically on cancer patients, because cancer patients face unique challenges, due to a range of factors focused on cancer being the indication for surgical resection involving their stoma. And those range of factors include, dealing with the life-threatening nature of a disease, neoadjuvant or adjuvant chemo or radiation therapy on their well-being. So that was, a big limitation for us. And that is it.
All right. Debra, why don't you step to the
Thank
screen
you.
and direct questions? Because we're coming back to this room, but while,
Yes. Does anybody have any questions for Jean-Ann?
I have
Yes.
a question. Was there in the literature any rationale for stating that only WOCRN can make the stoma sites?
Did you hear that, Jean-Ann?
For the stoma site?
Yeah.
Yes.
Like for the marking?
The marking
Yeah.
of the stoma site.
Yeah, just because of their advanced expertise in anatomy, because, they go through special, through training. So just for their, for it being site-specific and being able to sort of regard the type of stoma the patient's going to need, as well as other factors like if the patient's obese versus if they're underweight or malnourished. But that was really the only reason that I saw in one of the standards, in one of the literature reviews. I don't recall offhand which one, but they were quite clear that an RN should not be doing that. But if in the absence of a WOCRN, the surgeon or a fellow could mark the patient.
I'm just thinking that the surgeon or the fellow giving up that responsibility might be a little bit difficult.
Yeah, did you hear that, Jean-Ann?
I did. I wasn't able to hear that. I'm sorry.
Said that she was thinking that the surgeon or the resident who was going to do the surgery would be seeming to give up that responsibility for marking the place where the surgery would occur. So she was thinking that would be a little bit difficult.
For the surgeon not to do that?
For the surgeon to give up.
That, in other words, the surgeon would be giving up marking out the place where the surgeon was going to do the surgery.
Yeah, I mean, I don't have a specific answer as far as what the literature showed for that. I do know that when I shadowed one of the outpatient WOCRNs, just based on the actual surgery and, the anatomic location, she then would look, they have a whole process, and they would then look exactly, at the patient's, body type and see just long term where this stoma would be placed that would least affect the patient.
Yeah.
And that would be just the most sustainable for quality of life, afterwards. But as far as like anything that was in the literature, that I did not see.
Okay. Does anybody have any other questions for Jean-Ann? I just have one quick question for you, Jean-Ann, and that was, you did a lot of working with other people to develop these standards. I know that you started out with the idea it was going to be one standard, then it blossomed into 4 standards. What did you learn about the clinical specialist role from this project?
Well, I learned from my preceptor, who's the CNS for inpatient, that she's really just sort of she was actually sort of the key link person between the inpatient and outpatient, and sort of linking everyone together, on this. But I also, because the outpatient and inpatient, there is a bit of a, sort of, not a communication gap, but everyone's kind of in their own, world doing their own thing. So the role of the specialist was to kind of bring everyone together and say, okay, everyone's doing a great job so far, but we need to make this standardized for our patients, so that a patient in genitourinary outpatient is doing the same thing as the patient, they're receiving the same treatment as the patient who's in colorectal outpatient. They're getting the same, sort of education.
Yeah. Okay.
Yeah.
Thank you. So
thank you.
Thank you. Let's finalize that again. And Jean-Ann, I'm going to take control away from you. So
okay.
As you know, when I start moving things around, I have the control and you don't. I don't know, Ryan, you're up next. Know that you're up next. I believe you're up next. So go, hurry back.
You want to go last?
You want to go last? That's fine. Maria's up next then. So what I'm going to do is bring up Maria's.
I need to put this because some of the
I know.
slides, the information has been cut off. I need to bring this with me for me to see the information.
Oh, okay.
Because it's, some of the information has been cut off.
All right. What you can do then is you can either use the mouse is here. All right. The mouse is here, but you have to forward back and forth here. Okay.
Thank you.
So those of you who are on the outside, Keith, looks like Keith just arrived. Hello, Keith. Hope you can hear us fine. And I'm going to turn this over with Debra's introduction of Maria Del Mar Rodriguez.
Okay, so I'm going to introduce Maria Del Mar Rodriguez. She's our CNS student in the Postmasters program. And she's going to talk about postoperative handoffs, something that was very dear to her heart as an OR nurse at Sloan Kettering. And take it away, Maria.
Hello. My name, I work in the main operating room of Sloan Kettering, but I did most of my most part of my clinical rotation took place in the post-anesthesia care unit in PACU. So the topic I chose, I wanted to choose a topic that it was related, closely related to the operating room and PACU, as I didn't have much experience in the PACU. So while I was doing my clinical rotation, and based in my experience working in Europe, in the hospital, we have the pre-op area, the intra-op area, and the post-op area. So patients, when they were traveling in the peri-op environment, nurses, we always went to the pre-op area to get handoff, to know about the patient after being assessed. And then once the patient came into the operating room, during the intra-op area, then we had the handoff during the intra-op transition. And then once the patient moved into the post-op area, in Europe, we did that. The nurse followed the patient to the post-op anesthesia care. But here in my hospital in MSK, the peri-op environment does not support the handoff from pre-op. It supports from pre-op to intra-op, but then when the patient is moving from intra-op to the post-op care, the nursing contribution is not being considered. So I thought there was a bit of omission in information between that transition from intra-op to post-op care. So the topic I chose, it was postoperative handoff. Sorry, my title. Sorry. Oh, it's true. So it is postoperative handoff, the effect of operating room nurse to PACU nurse handoff on the overall postoperative information exchange. So these are the objectives. By the end of this session, you will be able to identify the benefits of the nurse-to-nurse handoff from OR to PACU. You will be able to identify the risks associated with incomplete post-operative handoffs. You will be able to list 3 key pieces of information that should be included in the OR nurse-to-PACU RN handoff, and identify a variety of methods used for handoff information. So what is the significance of my topic? As I mentioned before, currently in MSK Memorial Sloan Kettering, peri-op environment supports the handoff from pre-op nurse to intra-op nurse. But the intraoperative nursing contribution is not considered when the patient moves from the OR to PACU. So we all know that post-operative handoffs take place within a short time and are prone to communication errors. Failure to communicate relevant patient information from one care provider to another during post-op handoff may contribute to gaps in patient care, compromising patient outcomes. 3 agencies. The Joint Commission, the Agency for Healthcare Research and Quality, and the Institute of Medicine, they all support the handoff process to improve patient information, the patient safety. So the first step was the identification of the problem. So the problem, as I mentioned before, current handoff practice in the peri-op environment includes RN to RN handoff from pre-op to intraoperative area, but this handoff process is not continued from the intra-op to the post-op area. So the question is, should all members of the surgical team participate in post-operative handoff process? What information is being lost by omitting this process? And if this handoff was implemented, would it improve patient outcomes? At the moment, the handoff from OR to PACU is done by the CRNA, the anesthesia nurse, and the surgeon. So I outlined my clinical question in a PICO format as follows. In the post-operative handoff, how does the OR nurse to PACU nurse handoff compare to the physician anesthesia to PACU nurse handoff affect the content of information? So these are the various sources of information and search terms I used to gather all the evidence. So in total, I found 28 articles that dealt with the post-op handoff. 10 of them were relevant to my topic, and I decided to keep 6. How did I synthesize the evidence? To organize my information, I used tables, the evaluation table, the levels of evidence table, and the outcomes table. So that's where some of the information has been cut off. This is the evaluations table. Here we have, on the left-hand side, we have the article, one of the articles. And this is all the background information to my core findings. This table. This is the second article. I used 6 articles. So then we have the level of evidence table. At the top, we have the 6 articles and the level of evidence. Most of them, they were quality improvement projects, and 4 of them, and 2 of them, they were guidelines and AORN, American Association of Operating Room Nurses recommended practice. So then we have our outcomes table. At the top, we have the 6 articles, and then we have the outcomes. And most of the articles, in terms of outcome 1, they shared that the OR or a nurse is included in the PACU RN handoff. In terms of outcome 2, PACU nurses satisfaction, half of the articles shared that PACU nurses satisfaction was increased. 3 of them showed no evidence. In terms of outcome 3, all articles shared that there was an increase in overall patient information transfer if you included the operating room nurse into the PACU handoff. In terms of outcome 4, 5, and 6, they're all methods of handoff information. Outcome 4, face-to-face. Most of the articles support this face-to-face handoff information, and outcome 6, which is verbal. Outcome 6 is verbal information. So most of the articles face-to-face and verbal information, handoff information. So 3 evidence-based practice recommendations emerged from these articles. The first one is that all relevant team members should be present during post-op handoff to ensure complete and accurate transfer information and support patient outcomes. That all institutions should be implementing a standardized and structured OR to PACU handoff. And it should be a face-to-face, verbal, or written handoff report included in the OR and PACU RN. So, measurement plan, that was all external evidence. Then I looked into MSK Memorial Sloan Kettering and the opinion of my colleagues in PACU and the operating room. So to do that, I conducted a survey to explore the OR and PACU nurses' perceptions of the contribution of circulating nurses in the postoperative handoff process. There were 30 surveys, 30 participants, 15 operating room nurses and 15 PACU nurses. And this is the questionnaire. And we have the scale from 1 to 5. 1, strongly disagree, to 5, strongly agree. So we have 6 questions. Okay. And now we have here the survey findings. There is a lot of information here, a lot of detail, but I just wanted to highlight some of the numbers. So we have the scale from 1 to 5, and then we have the questions. So I just wanted to highlight that the 40% of the nurses, they remain undecided about including the operating room nurse into the PACU handoff.
Maria, you can use the cursor to circle where you want people to look.
Sorry for
So if you take the cursor and put it where you want people to look, they'll be able to see it. See the cursor? See the little arrow? Yeah, just point to it. Don't look there. Look at your screen. Look at the screen in front of you.
Sorry.
Yeah, they're right there. You'll see it. So move it, and that way you can point to it.
Perfect. So 40% of the nurses remain undecided about including the operating room nurse into the PACU handoff process. Here, 60% of the nurses strongly agreed that patient positioning during procedure should be included in the handoff process. 67% of the nurses strongly agreed that patient sensory or motor limitations should be included in the OR to PACU handoff process. Oh, so fast. Now, here is 80% of the nurses. Give me a second, please. 80% of the nurses strongly agree that patient's skin condition and pressure ulcer risk assessment should be included in the post-op handoff to PACU. 67% of the nurses strongly agreed that special needs information should be included in the OR to PACU handoff process, and 87% of the nurses strongly agreed that isolation precautions should be included in the OR to PACU handoff process. This graph represents the results to the first question, which is the key question. Should the OR nurse, operating room nurse, should be included in the post-op handoff to PACU? So as you can see here, most of the weight is to the right-hand side towards agreement, although you see 40% of the nurses click the middle box. They remain undecided about including the operating room nurse into the handoff, PACU handoff. So this is just a breakdown of the same question, showing you this, that most of the 40% of the nurses, 27% of the nurses who remain undecided, they were PACU nurses, and the ones who mostly agreed were in the blue here. They were OR nurses. So here it shows a summary. This graph shows a summary of the answers for each question. So you see that question one, most of the nurses remain undecided about including the OR nurse to PACU. But then the information on question 2, question 3, and question 5, most of the nurses agreed that information should be included in the post-op handoff. And the information regarding question 4 and question 6, which was the skin condition and the isolation precautions, nurses strongly agreed that information should be included in the post-op handoff. So this shows question 7. This graph shows the information that it is currently provided in the current handoff process. So what it shows here that regarding question 2, which is patient positioning during procedure, question 3, sensory or motor limitations, 4 and 5, as you can see, it is rarely communicated. To question 6, isolation precautions is always more frequently communicated, but as you can see, inconsistent. So the survey findings show that the handoff information PACU RNs consider important in the post-op handoff is the same information that it is rarely communicated by the surgeon and the CRNA in the current handoff process. The current post-op information transferred from OR to PACU is often inconsistent and incomplete. And even though nurses supported the need to include survey information, all those the information on those questions, less than 50% of the operating room and PICO nurses agreed to have the operating room nurse included in the handoff process. So the pertinent missing information, we had the skin conditions, pressure ulcers, rash, that is this hardly ever communicated to the PACU RNs, positioning, which can lead, position information which can lead to deep tissue injury and compartment syndrome. We have several cases in PACU due to the positioning of the patient during the procedure. And then the psychosocial needs information like anxiety, special needs, and suicide precautions. That is never communicated to the PACU nurses by the CRNA and the surgeon. And the thing is that as you, Jinan and Jean, they talk about the ERAS pathway. So now with patients being mobilized faster in PACU, some patients who are on suicide precautions, as they are early mobilized in PACU, so they go to the bathroom, they go. So there is a risk in that, and the PACU nurses are not aware of that. So how did we disseminate this information? We shared the results of the survey with OR and PACU RNs. It was well received. So we proposed implementation to include the operating room in the post-operative handoff process, which is currently taking place. They have been asked to present these findings in front of the Peri-Op Coordinating Council to see if it can be implemented. So we propose a plan to incorporate survey information into the handoff process. So, any questions?
That's very good.
This is a comment. What jumped out to me is when you indicated that when you searched the literature, you were only able to find articles that were quality improvement and protocols.
Yeah.
So that says that there's a need for
more research.
So maybe you could include that in your recommendation.
Mm-hmm. You're right there. Thank you very much. You're right. Yeah, because there is a lot of research on the pre-op to intra-op, but that is not from the intra-op, post-op, because it's not taking place in most of the hospitals. Because they are worried about extending the turnover time of the in the rooms. So if the operating room nurse goes to PACU, that is a waste of time there. So some of the hospitals, all these quality improvement projects, they had the operating room nurse included already in the post-op handoff, and during their project they didn't remove it. They kept. They thought it was valuable, their intervention. But yes, it should be done.
So to be clear, you've recommended implementation of this, but it has not been implemented.
No, I am in the process. They are in the process. I am in the process of presenting it in front of the council. And then,
in those quality improvement projects that you researched, did the two recommendations that stood out to me was the decrease in happies, and then dissemination of hospital-acquired nosocomial infections. Did they look at those in those quality improvement projects, like if they implemented this recommendation, and did they see a decrease in happies and to see a decrease in nosocomial infections?
In this project, they perceived an increase in PICO satisfaction, nurses' satisfaction.
Satisfaction.
Yes.
But there's no objective measure.
Yeah. And as well, an increase in the transfer of information, more information. No, there was an increase that was a benefit. That's what they, and the dissemination, most of them emphasized that the operating room nurse should be included.
Well, I mean, I work in oncology, and at Sloan Kettering, and all those patients are oncology patients, and I'm just thinking, they're oncology patients as a whole are immunocompromised.
Yes.
And it doesn't matter when they go to OR, that pathogen goes with them.
Yes.
And we should have that heightened awareness, regardless of where they are in the hospital. So I would love to see, if this was implemented, the objective measures of your decreasing nosocomial infections across the hospital.
Oh, not just infections and
then happiness as well, too.
Happiness as well. We have as well in complications like compartment syndrome.
Yeah.
During my clinical rotation in PACU, I did observe some of the patients because in the surgery in these patients, in oncology patients, you don't know the duration of the procedure because sometimes you don't even know what you are going to find. So the length can be increased. The positioning to provide access to the surgeon, it is unusual. So that can cause complications as well. If doctors, surgeons, and CRNAs, their focus is on is on the surgery. It is in the anesthesia management, pain management, but not in the positioning, skin conditions. So we have had many cases in PACU that they have compartment syndrome. Young people who are not usually the criteria is if an obese person, if after a long stay in the operating room, can have get a compartment syndrome by young people. So we had a few cases that young people getting compartment syndrome, developing compartment syndrome, and they have to be back into the operating room. And one of them lost a limb just because of that piece of information. So that's why I was approached to check this. But yes, I couldn't find any randomized trials and any level 1 evidence. Quality improvement projects and the AORN, which is one of the most important. They make these recommendations, but not all the hospitals are taking this. They're not mandated, they're just recommendations. So yes, I would love to do it.
I think it's fantastic.
Yeah.
Excellent.
I have a question. Yeah.
Excellent. I'm going to let Debra move over, but we do have to get this going because otherwise we're going to run out of time.
In regards to your survey, in regards to the survey, you had mentioned that one of the survey findings was that the OR nurses were more in favor of implementing the handoff to the PACU versus the PACU. I imagine that must have been an incidental finding.
I was surprised that PACU nurses. I didn't put the comments that I got because it was not included in one of my questions, but the comments, PACU nurses, I was shocked to hear, said, I don't need like this. I don't need the information from our nurses. That PACU nurses, our nurses said, that is extra work for me, going to PACU. So if this doesn't get implemented, I think it is due to they believe it is extra work for them. And PACU nurses, they believe it is not important. While they think all this information is very important for patient care and preventing complications. But then I was shocked at the end that our nurses were strongly agreed that they should participate in the PACU.
Okay.
Yes, it was
versus the PACU nurses.
Yeah.
Right, because I thought that they would need the information.
Maybe you can continue
They don't
a
need
little bit
information. They're the ones
afterwards. I
providing
want
the
to
information.
present Joseph Brian Tebo, who's one of the fourth of our students in the Postmasters program this summer. And Ryan is going to present his work on standardized protocol for managing hypersensitivity reactions in patients receiving blood products. Take it away, Ryan.
Hi. Okay, so let me first start with, what is a standardized protocol? And simply, standing orders. So an example of this would be an electrolyte protocol at the first hospital I worked at. If the potassium is less than 3.5, infuse 10 mil equivalents, 20 mil equivalents, The purpose of this was to explore whether or not it was appropriate to have a standardized protocol for hypersensitivity reactions that are patients receiving blood products, because, you know, these oncology patients can be very sick, and it's only complicated by the comorbidities we have in our population, and the American population. And time is of the essence. And, you know, the quicker you can implement an intervention, the more positive patient outcome. And so this was just what that was. This is just the 4 types of hypersensitivity reactions. Just for some background, type 2 hypersensitivity reactions are typically where you have the ABO incompatibility for blood transfusion reactions, just as a quick background there. And we're going to be focusing just on that with some other additional blood transfusion adverse reactions. Per the CDC, there's 12 types. I bifurcated it here in your immune-mediated reactions. So you have your allergic, your transfusion-related acute lung injury, your transfusion-associated graft versus host disease, and so that's like a bone marrow transplant patient. And then you have your febrile, non-hemolytic, your post-transfusion purpura, your acute hemolytic, your delayed hemolytic, and your delayed serologic. And then you have your more overloading reactions here. Taco is a big one. That's kind of delayed. I've seen that in the ICU a lot in my practice. Transfusion-associated circulatory overload. The reactions here that are starred are the most common. Okay. 85 million units of blood products are transfused worldwide annually. In the US, that is 21 million blood components transfused annually. I have it out here in the incidence of, and then these are, I believe, worldwide instances. If you look here at number 2, the febrile non-hemolytic transfusion reactions, the star there is that if you leukocyte reduce units, you markedly reduce that specific adverse reaction. And so that is the AABB, the American Association of Blood Banks, that is now called the AABB because they're a worldwide organization. They've recommended that across the board. And then in hospitals nowadays, when you're getting packed red blood cells, they're going to be leukocyte reduced to mitigate any kind of adverse reaction. I'll point out here that hemolytic fatal reactions are 1.1 and 1.8 million, which is rare. And then even rarer of these reactions is you have physical or chemical destruction of blood, which is even very, very rare, which you can have an adverse reaction because, you know, the cells have lysed because of mishandling or poor storage, so on and so forth. Okay, so the situation here is when transfusing blood products, there was no standardized protocol for managing hypersensitivity reactions. In the outpatient setting, where I was precepting, the hospital protocol was to call a rapid response. And the problem therein lied that Sloan Kettering as an institution is decentralized. And even where I was precepting in the main hospital, that oftentimes the rapid response providers would not know where to go because they're not accustomed to going to those areas. And so that's kind of where this bore out to is, you know, if these logistical issues, what can the nurse do? The nurse is at the bedside with the patient, chairside with the patient. What can she do in the moment to help positive patient outcome? And then inpatient, it's a provider and or rapid response is how they're managing these hypersensitivity reactions. And so my PICO was, in patients receiving blood products, how does standardized guidelines to manage hypersensitivity reactions compared to no guidelines affect patient outcome? I know this is a busy slide. I'll parse it out here. So this is the medical procedure. There was the nursing procedure was basically stop transfusion. The previous slide, stop transfusion, call rapid response, notify the provider. So this is the medical procedure on what the residents and fellows and the attendees are supposed to do. And then, of course, it was a medical procedure, but, you know, the nurse is doing a lot of this. So the nurse is going to be checking the blood component label. They're going to be checking the patient ID wristband. And this is upon an adverse reaction, to be clear. That the nurse is going to double check the transfusion slip for clerical error for all symptoms accounted during or following that transfusion. And if there's any itching or urticaria localized to one body part, the transfusion may be paused and restarted after complete resolution of the symptoms, with or without pharmacological intervention. If symptoms do not resolve quickly, then the transfusion is discontinued. For a temperature elevation of greater than 1 degree centigrade, 1 equal greater than or equal to, and greater than or equal to 38 degrees centigrade, discontinue transfusion and disconnect infusion set. And then this is any symptoms listed here, discontinue the transfusion. So coughing, blood in the urine, cyanosis, dyspnea, wheezing, hypoxia. I actually went to a rapid response where the initial symptom, and then I applaud this nurse, the initial symptom was decrease in oxygen saturation. It was, and so here, discontinue the infusion for O2 sets less than 90% on room air. And then in all cases where the transfusion is discontinued, the procedure is to, and of course the nurse would do this, immediately send a signed and labeled post-transfusion specimen to the blood bank with a component bag, filter, infusion set, and completed transfusion reaction form. This is hospital procedure, but this is also New York State law. My search strategy was an Embase and Cinol, and then those are my search terms there. I won't belabor that point. I found two, I believe there was, the problem I had with my search strategy is I had to limit it to, you know, the adult population, because I'm adult gerontology CNS program. And a lot of the articles I found were for either pediatrics or OB patients. And I didn't think that was appropriate, so I really had to drill it down. And I found about 24, and I selected these 7. There wasn't specific research or evidence that I found in regards to a nurse-specific standardized protocol or guideline. And so what I did is I parsed through the research, and I found, you know, prevention and interventions, prevention for an adverse reaction and intervention once one occurs. So you would prevent one by leukoreducing, you prevent one by irradiating the product, you prevent one by multiple patient identification, you prevent one by avoiding needless transfusion, you intervene by stopping the transfusion, notifying the licensed independent practitioner, maintaining the patient IV, checking vital signs, and comparing the unit to the patient. And then just for, you want to know what the standards are out there. So the evidence is based on standardized guidelines, and standards are based on evidence. And the Infusion Nurses Society standards of care when managing a suspected transfusion reaction is everything that I found. So you stop their transfusion immediately. You perform that clerical check of blood component labeling and patient identification. You notify the clinical team. You complete that transfusion reaction evaluation request. You send that blood bag, transfusion set, and anything else connected except the needle. And you would, as well as newly drawn blood specimen to the laboratory using a lab. And if the patient has a urinary catheter, and then this is, checking for that blood in the urine, examine for any kind of, in cases of like hemolysis. And then you would consult with the LIP to determine whether or not you need any additional labs and then this is actually, so the Infusion Nurses Society, they have this little thing here at the bottom in regards to, they don't explicitly state that it's okay to restart the transfusion. They say that some hospitals do that. And so it's not a complete contraindication as far as they're concerned. And so that's kind of why they mention it there. So this is the American Association, or the AABB, right? They changed their name. This is their standard of care. This was a fun little graphic to create here. These are your three typical symptoms that you start with, and then I parsed it out here with, if you have your fever, how bad is the fever? And so, like, for instance, if your fever is less than 39 degrees, plus you have low BP, plus you have tachycardia, or if your fever is greater than 39 degrees, then it's probably acute hemolytic reaction or bacterial contamination. And then you have, if you have a rash or urticaria, it could either be a minor or a major allergic reaction or anaphylaxis. If you had dyspnea, shortness of breath, and decrease in O2 saturation, plus hypertension, it can be the transfusion, acute lung injury, or it can also be an acute hemolytic reaction or bacterial contamination. But in all instances, just to belabor this point, you're stopping that transfusion. And then again, that's the AABB standard of care there. You're stopping that transfusion, you're checking in monochain vital signs, you're maintaining IV access, you're confirming the right unit for the right patient, and you're notifying the LIP and the blood bank. And then this is additional interventions that you would do based on the possible etiology. I have anaphylaxis highlighted there because you're going to initiate BLS. And then the investigation on whether or not to confirm your possible etiology is there on the right there. So if it's anaphylaxis, you're initiating your BLS, you're taking care of your patient, and then you're doing a type-in screen and you're looking at their hemoglobin and the IgA levels. And then all of these, you're going to be doing a type-in screen with the exception of transfusion-related acute lung injury, where you're just doing an HLA and HNA antibody antigen testing. Okay. And then the AABB standard, I also do want to point out here that they do say that it's okay to restart the transfusion so long as the reaction subsides. So my recommendation here, that there was no change because of that there's no change in current hospital policy. And based on the Infusion Nursing Society, AABB, and my evidence that the restart of transfusion is only in resolvable cases of itching or urticaria on one body part. Any standardized protocol or guideline would only be appropriate in those cases. And all other cases, the transfusion is discontinued. The potential for rapid development of life-threatening adverse reactions is far too great. So the LIP should evaluate the patients in all instances of transfusion reactions. So regardless of the presenting symptoms, the LIP should be the one that's determining whether or not to continue the transfusion or discontinue the transfusion. And they're at the bedside or chair side, ordering those interventions. A lot of this would be a lot of the interventions would be outside of the scope of practice for the nurse. And so on the subject of that, I was wondering, the evidence says one thing, the standards and the guidelines say another. What does New York State law say? So I found this clinical practice guideline from the New York State Council on Human Blood and Transfusion Services, which is the Department of Health, and the New York State Board of Nursing, and this is verbatim from them. If a patient is at increased risk for a mild reaction, a PRN order of Tylenol and or Benadryl may be useful in order to facilitate immediate availability in the patient care area. So per the State Board of Nursing, this is all you can do. There's nothing more. So a guideline would be great if evidence pointed to additional guidelines for nursing intervention at the bedside or the chair side. But the State Board of Nursing and the Department of Health said, and I do want to emphasize, they say may be useful, not should be, could be, would be, maybe. And then here are my references.
Great.
Any questions?
In the operating room, we see many patients who have febrile symptoms due to previous reactions to blood transfusions, and immediately we give Tylenol and Benadryl. That is the protocol.
See, and then the problem I have with that then is if it's,
And they give blood.
you know, if it's a worse, if you go back to this here, you could potentially be masking an acute hemolytic reaction or bacterial contamination if you're giving Tylenol and Benadryl as a nursing intervention.
Yeah. Yeah. That's good.
But I mean, you could also be mitigating a major allergic reaction too if you're giving an antihistamine sooner rather than later.
Do you
But
think,
yeah.
can I just ask you a question? Do you think that this standard needs to go together with like a fever workup type of a standard? Because if they're having a fever related to this, there should be almost like some kind of a segue into fever workups, particularly when people are inexperienced and don't understand that if you're going to be taking blood and sending it off, especially if you're looking for sepsis and things like that on the horizon, you don't want to necessarily be giving Tylenol up front. You want to get your things done, your labs done first, and then do that.
That's a very good point, and I'm not sure, you know, in the protocol where they said, no, it didn't say just discontinue. It didn't say as far as like pharmacological interventions.
Yeah.
So yeah, I do know, I can't speak for Sloan Kettering, but I know at my hospital, for neutropenic fevers, there's a very specific policy and procedure on what needs to be done in regards to investigation and the time frame on, like for instance, if a patient is out in the community, they're given a special fast pass card for those immunocompromised patients. So they're given a fast pass card for the ED, and if they have a fever, they're to present this fast pass card at the ED, and you know, evidence to show that they need to get antibiotics with a very concise time frame in order to mitigate sepsis. And so, yeah, I mean, I agree. I don't know if there is one in specific to transfusion adverse reaction, but yeah, I think that would be very concise.
What about using autologous blood for people who already had previous reactions to blood transfusion?
And I'm very familiar with that, with like cell savers and
yes, cell savers.
There's, my understanding is that there's no reaction with autologous blood. And you know, sometimes patients do that. You know, she's mentioning that in the OR, if you're going for elective surgery, you'll bank some of your own blood in case you do have blood loss during surgery. Or they have these devices that if they'll collect any blood loss, they're called cell savers. They collect any blood loss during surgery, and at the conclusion of the surgery or on the PACU, you'll get all of your blood back. Or if you did have blood loss, then the blood bank has your own already donated blood and they can give back to you. And my understanding is like that's the only blood product that we're giving via gravity, because that can go right into them. Those are their cells. I mean, there's no contraindication. They can go right in. And it's just like, you know, the OR nurse I was talking to about cell savers is like we slam it into the patient. But yeah, that's a very good point. But unfortunately, you know, in the oncology population, you know, they're immunocompromised or they're pancytopenic because of chemotherapy, and so you can't really do that with that population. It would work great at HSS, but not so much at Sloan Kettering or even at my service line.
We use it mainly for Jehovah's Witnesses. For religious purposes, we always had the cell saver.
Yeah,
But not really because of hemolytic reaction.
Yeah, we also use Procrit, which helps stimulate red blood cell production for Jehovah's Witnesses.
Thank you. Let's give a final applause. But I want to show you what it looks like. So that's how, folks, it looks like Julie and Keith were still on, so we'll say goodbye to you on the outside. And I think Diane might be, but I know your classmates, if you saw them leave, so you can see when they come in and out. Very nicely done, everyone. I want to thank you all for coming, and any other kinds of follow-ups. If this works, you'll be able to see it on video. If it didn't, my apologies in advance. Keep them. I want to make sure.
Oh, 4 minutes over. Okay, great.
Good. How are you?
Thank you. Good job.
My queen really needs to
Oh, no, I don't. Yeah. Do you want me to give it to you and you'll come to
Yeah,
just have a chance to set it. Yeah.